Well, good morning. Good morning, all. So glad to see you here on this lovely Tuesday morning. Welcome to Medical Grand Rounds. A reminder, next week we have one of our special endowed lectureships, the annual Lipschitz Lecture, and we'll be hearing from Dr. Rob Orman. Dr. Orman was actually previously an emergency medicine physician here at St. Vincent's and is now the voice of the international podcast ER Cast. Should be a fascinating talk. Today, I'm delighted to introduce a familiar face to many of us, Dr. Roma Moza. She's a practicing hospitalist in medicine as well as pediatrics here at St. Vincent's since 2018. She earned her medical degree from The Ohio State University and then did residency in internal medicine pediatrics at Baylor College of Medicine in Texas. She was involved there in community service, leadership, research, and education, earning herself the 2016 Distinguished Resident Educator Award. And it is no surprise that Dr. Moza has quickly established herself here not only as an outstanding clinician, but as a talented and passionate teacher, very much engaged with our internal medicine residency program. And on that note, I'm going to briefly turn introductions over to our current chief resident, Kate Marshall.
Yes, you are. Yes, so Dr. Moza quickly made a big impression on all of the residents, and since you weren't here to accept your award, yes, you have Outstanding Teaching Hospitalist of the Year from last year.
Couldn't avoid the public embarrassment, right? I think that's what's about to happen for the next 45 minutes.
Nothing to live up to.
Oh man, that's funny. I was like, what's about to happen? Good morning, guys. Good to see all the familiar faces in the room. For those of you guys who don't know me, so I'm a med-peds hospitalist, and one of my passions is kind of talking about the transition population, a complex group that we really don't think about on a day-to-day basis. And so hopefully over the next 45 minutes, we can kind of gain a new perspective about caring for a changing population. I have no disclosures. However, if anybody wishes to fund me, grant me, or give me some finances, feel free to Venmo me at Roma Moza. Appreciate it. So I always like to start any talk with kind of questions, thinking about, well, when I walk away from here, what questions will I be able to answer and what lessons am I going to learn? The first is, what is a med-peds moment? So I'm obviously med-peds trained, therefore this happens to me all the time, but I really want to share some clinical vignettes to help the audience kind of reflect on your own clinical experiences and think about where have I actually used the intersection of pediatric care and adult care in a single individual, and that's what we call like a med-peds moment. The second question that we're going to kind of reflect on and think about is, how do adults with childhood onset diseases challenge us? So we know that they challenge the healthcare system, but also how do they challenge us as providers when we're trying to take care of them in a clinic, in a hospital, out in the community? And then finally, the dogmatic question of, can I treat kids as little adults? All pediatricians and family practitioners will scoff and say no. However, I'm going to present a clinical case at the end of the talk to kind of wrap up and really expand our thinking as far as, okay, well, maybe there's some gray zone with that question. And so, as was introduced, I've only been here for 1 year, but I thought that I would start with a trip down memory lane and think about cases over the past year that I have seen that were very med-peds moments here at St. Vincent's. And so, again, what is a med-peds moment? So I call it the simultaneous application of pediatric and adult medicine principles for patient care in a single individual. And so one of the groups of patients that my group actually manages on a regular basis are eating disorders, and all of my med-peds colleagues will be groaning as I publicize this to everybody. But St. Vincent's actually gets transfers from other hospitals for adults who have eating disorders. And eating disorders in itself is a transition kind of concept because a lot of times it starts in adolescence and goes into adulthood. And the nice thing about here at St. V's is that we've created a program where nursing staff, nutrition, social worker, the physicians themselves, we and case managers really work on figuring out how to transition these patients out of the hospital where they don't keep coming back. And so that in itself is a specific population at St. Vincent's that we take care of that is a consistent reminder of having med-peds moments. Now this case was like a med-peds moments on steroids is what I call it. This was a 19-year-old who has autism spectrum disorder, OCD, and she was under the guardianship of her parents, and she's being managed for severe protein-calorie malnutrition from her eating disorder. So in this case, not only do we have the component of just the eating disorder, but at the same time you have a mental health illness and a family dynamic that is changing your everyday rounding. So she was at the intellectual capacity of a 19-year-old. She had a behavioral capacity of probably a 10-year-old. And you had to deal with figuring out how to advance her care by using a shared consent model. And that's something that very commonly is used in the pediatric care, but not necessarily a lot in the adult world, unless you're kind of dealing with more geriatric populations. Now, a lot of times we think transition population and you're like, all right, most of them are between the ages of like 18 to 35, and once they get older, they're like full-blown adults. I don't really have to be thinking about how pediatric care applies to this. But I will challenge you guys to think about what happens when a middle-aged person or an elderly person comes in with an illness and you're like, oh, I haven't seen somebody like this. It's a 52-year-old with Down syndrome. Has anybody seen a person this old with Down syndrome before? Yep. So it is becoming more and more common. Fortunately, kids with chronic illnesses are surviving longer, and they're going to survive into older and older ages as technology advances. And so it was on triage where I got the call for this gentleman, and he was admitted for like a mechanical fall and some mild delirium, which honestly resolved within like 24 hours of some hydration. And his brother was his primary caregiver, and he was like, I think he's at his baseline now. And we were like, okay, wait, this doesn't look right. Like, this can't be your baseline. This isn't safe for going home. And so, of course, we think about DISPO, fall risk readmission issues in the hospital. And so we had our great therapy services here at St. Vincent's kind of do more of a cognitive eval. And he was actually diagnosed with specifically Alzheimer's dementia. Now, a lot of the audience is probably thinking, okay, he's 52. How did he have Alzheimer's dementia? But people with Down syndrome are actually at increased risk of dementia because of increased deposition of the protein in their brains. And so it's one of those things where you kind of have to have in the back of your mind a red flag trigger and saying, okay, something's not right. And he was actually discharged with palliative care and managed to avoid coming back to the hospital and is now, I presume, safely at home, having a good quality of life. And so this really is what I call a pediatric knowledge base applied to medical, like adult medicine aspects of care, because here is a middle-aged adult where diagnosed with dementia, discharged to palliative care is a very common occurrence, right, in the adult world. But it's in a patient who's 52 with Down syndrome. And so you're applying your pediatric knowledge to this case. The last vignette that I wanted to share and kind of reflect on is in subspecialty care, a lot of times we think, okay, they can be siphoned off into their super specialized world and we don't really have to worry or think about these patients. But our team was actually consulted on a 28-year-old obese gender-neutral patient who has a diagnosis of non-ischemic cardiomyopathy since the age of 15, secondary to a preceding viral illness. And we were consulted just for their diabetes management. And so they obviously were being primarily managed by the cardiology service for transplant evaluation, but had other issues in regards to gender dysphoria, obesity, diabetes, and gout in a 28-year-old. And normally you're not treating 28-year-olds, right, with this spectrum of illness. And the reality is that even though the driving factor of their admission and their medical problems is their heart, the reality is that they have other medical conditions that fall under the general medicine purview. And so while we like to fool ourselves into thinking like, oh, that sickle cell patient will follow up with hematology, that adult congenital heart patient will have their cardiologist, that IBD patient will have their GI doctor. As you get older, you are still susceptible to the ailments of just typical adult problems. And so we really have to equip ourselves to being comfortable with taking care of the associated problems with the subspecialized care. And the more patients that are surviving and the more that they shift towards that adult practice care, the more it's going to fall under the general medicine purview, because there's just going to be simply too large of a volume to say, hey, you can kind of stay in these tertiary care centers. And so a couple of hands were raised with like the Down syndrome and for that case, and I'm just kind of curious if other people have had med-peds moments in either the past year or in their lifetime of clinical experience and practice. So again, the reason for this reflection is so that we can self-recognize when these moments happen, and because when you recognize when the moment is happening, then you can change your framework, have a more effective patient encounter, and you can also know what resources you might need to connect that patient with. And so as you guys are reflecting, what I have up here is a list of diagnoses that are the top 6 diagnoses of childhood onset diseases in adults. So cystic fibrosis does lead the charge. I think a lot of that is because more has been done for advancing their care in terms of foundational work and like community support, because that's where there's been the most like increase in mortality benefits. Childhood malignancy, unfortunately, long-term survivorship is definitely becoming more and more common, which is a great thing. That means that our therapies are actually working. Sickle cell disease, which I honestly haven't seen too much of in Oregon, but saw plenty in Dallas. And then congenital heart disease. Intellectual disability, which also falls under the previous cerebral palsy, which I have seen a couple of cases here at St. Vincent's of that. And then childhood onset epilepsy, which is a little bit different than like your typical adult epilepsy, because they tend to be more refractory on more atypical medications and have a different type of support system at home. And so as you guys are kind of like looking at these list of diagnoses, I really would like to encourage the audience to think about, okay, when have I had moments where a patient may have had this issue? And you may have only seen them for like cellulitis or pneumonia or like a viral URI. But at the end of the day, if you were part of their care, there was some aspect of their care, whether it was the medical knowledge that you had to apply, or whether it was the provider-patient dynamic, or whether it was the kind of resources that you had to connect them to, that made it a, what I call a med-peds moment. And so I love anecdotes and stories, but I also like to back up like what I'm saying with actual information to say I'm not just overblowing this population and saying that, hey, this is going to be a problem coming near you in 2021 or something. But every year, at least 500 to 750,000 young people with special healthcare issues become adults. And this was based off of a special healthcare needs survey from back in 2002. So this number is probably only getting larger. And so what this implies is that we can't, again, isolate this patient population to subspecialty care, tertiary care centers, or assume that it's isolated to just like big cities, because with those kind of numbers, they're bound to be out here in the community. And there was also a paper that looked at the total inpatient charges over a decade in terms of divided by age. So pediatric transitional population of 18 to 21, and then older than 21. And this was looking at adult hospitals. And what I really want to point out on this graph trend is that over time, so as we all know, all hospitals are getting more admissions, patients are increasing, clinics are getting busier. That's just the general trend of healthcare. And so that's reflected in kind of the increase in the general hospitalization over time, but there is an increase that is out of proportion to this in the transition population age of 18 to 21. Now, they artificially called it the 18 to 21-year-old age range for what the transition population is, but I would push the audience to say, and what I'm hoping at the end of this talk is that you don't really think about peds or adult or transition as age cutoffs, but rather from a more holistic view of where am I developmentally with this patient and what are their dynamics and where are they in becoming independent, like adult thinkers. All right, so hopefully everybody has kind of internalized some moment where they're like, all right, I've had a med-peds moment. I've got this. And more likely than not, there probably was some discomfort or some unknown when you were dealing with this clinical situation. And well, I'm just saying that because I personally have had that myself, and so I can only anticipate my colleagues to have felt the same. If you guys are experts and never had a moment of discomfort, kudos. Tell me what you guys are doing and what your tricks are. But I always say from moments of discomfort come a greater good. And I always think to myself, like, all right, how can I better serve my not only patient population, but my colleagues? So hopefully I can serve as a resource and a med-peds bridge so that that dip down from that moment of discomfort is a little bit softened, and the group can kind of walk away with a more confident understanding and framework for patient care. So I wasn't sure if I needed to cover this, but I'm just going to highlight it anyway. Why me, right? Like, why is a med-peds hospitalist the one advocating for this transition population or talking about these med-peds moments and talking about this subspecialized population that we have to take care of? And the reason, or when I reflect on it, it's because a lot of our experiences and our exposure is inpatient heavy. It's very hospital heavy, ICU heavy. Even in the ambulatory world, my clinic time was often in a subspecialty clinic instead of just in a general ambulatory clinic. And so the exposure during training and then subsequently in your practice tends to be that population because that's kind of what you gravitate towards naturally. And so naturally with med-peds, when you're doing the full spectrum, people end up in a variety of career outcomes in subspecialty care, primary care, global health, transition medicine, and hospital medicine. I am by no means going to claim to be an expert in the top three, but I really hope that my experiences with transition medicine and hospital medicine can really help inform the audience and provide a bridge towards improved care. So when I think to myself, all right, how can I help my colleagues? The second question I ask is, well, what do I think they need help with? Thankfully, I did not have to think up of ideas and creative solutions. Somebody actually studied this. So back in, it was 2005, there was a survey that was sent out to like 250 random internal medicine providers through the ABMS directory. And it was like a qualitative survey where they looked and they were like, all right, in this population that you have to deal with, what have been your challenges? What is actually stopping you from having a greater level of comfort in taking care of this population? And so this list that's out here is like by priority. So this is the top and this is the least of their concerns. And what's interesting is, I'm going to start from the bottom actually. What's interesting is that when you look at the pediatric published data, and what they talk about the focus needs to be, it's a lot of this, where it's a lot about health systems issues and a transition program and creating support workers and social workers and like a method to transition these patients, which don't get me wrong, that's very critical and important. But when you go to the flip side and you ask adult providers what they're concerned about, a lot of it is on the more individual basis. And so under medical competency, that was the category of what they kind of categorize the responses at, what the concerns were from the providers was that they felt that they didn't have enough exposure and knowledge of pediatric illnesses. They felt like they needed more exposure to adolescent medicine and those topics. And they also felt like talking about palliative care and advanced care planning for younger patients was very challenging. So having a 21-year-old that you're putting on hospice care is very challenging. And it doesn't matter if you're super trained to do so or you've never done it before. There are many, many aspects to it that are just difficult. And then the second two that they prioritized, I kind of find them kind of go hand in hand. When it comes to family involvement, it was kind of ironic because there was a response that said too much involvement and then too little involvement. So either that the parents were not relinquishing decision-making or their caregiver wasn't relinquishing decision-making appropriately to the patient, or that there needed to be more guardianship involvement because the person was just not ready to make their own medical decisions. So it kind of like, the pendulum swung both ways in the responses. And then with the patient's psychosocial needs, a lot of this had to do with expectations. How much time was the provider able to give for the patient? What is their expectation of their provider? How much was the provider going to go above and beyond? And a lot of that, having seen how the approaches to kids with complex illnesses and adults with complex illnesses, very different, because not many kids have a problem list of 12 things, but many adults have a problem list of 12 things. And so to an adult provider, this patient with complex illnesses is going to be treated within the same time frame as your other patient with a bunch of problems. And that's very different because in the pediatric world, they can frequently get like 45-minute appointment visits, an hour-long visit. They get a bunch of resources in the pediatric world. And so there's a lot of expectation management under here. And that was what providers kind of said was a big issue. So looking at these survey answers, I was like, all right, I'm going to translate this to the group and the audience that I'm talking to. And by no means I'm going to go through every single pediatric illness to improve people's medical competency. So I was like, okay, what can I actually help with? And so what I'm going to talk about to kind of help give you guys a toolkit to say, all right, we all are challenged by this patient population, these complex adults with childhood onset illnesses. But I want to walk away from this talk thinking, how can I make this better for myself? How can I make it better for the patient? How can I make it better for our healthcare system? And so I'm going to talk more about kind of the provider-patient dynamics and the family expectations, and a little bit about how we manage that to actually be more successful and a little bit more efficient. So in terms of what these pictures are supposed to show, I always say that life is a circle, right? We start, we're born, we can't speak, we can't even communicate, and our parents become, or whoever is the caregiver becomes the sole person as a translator for the world around us. And so in pediatrics, frequently, it's not the patient that's giving you the history, it's the parent. And because of that dynamic, right, you're forced to walk into a room and really engage and acknowledge the whole room. As the child gets older, what ideally happens, right, is they have experiences, they learn how to communicate, they learn how to make very hard decisions for themselves, and that progresses into adulthood. And then as an adult, the expectation is you're grown, it's time to actually make the decisions. And when I talk about risks and benefits of treatment, I'm talking to you. If there's somebody else in the room, that's great, they're your support system, but primarily we are driven by what that person says, right? And so adult medicine becomes more patient-centered from the family-centered version of pediatric care. And then as we get older, unfortunately, our faculties may decline. Here in Oregon, I found people's faculty don't decline until they're like 95. It's really amazing. The old people here are amazing, that's all I have to say. But eventually, it does happen. And so you encounter families where it's the children or the spouse or like the neighbor that happens to have lived with them over the past 30 years who ends up being largely their advocate in their clinical decision making. And so we, in adult medicine, right, subclassify that as geriatric care, and there's like extra training and talks and specialists who do that. And so what I really want to push the audience to think is that while there is a circle of life when you kind of go from family-centered to patient-centered to family-centered, at the end of the day, what's actually driving the changes in dynamics is the patient's psychosocial development. So while ideally a 30-year-old would make their own independent decisions, they may have had life circumstances in their prior 3 decades that prevent them from meeting that expectation or that milestone. And so as a provider, one of the first things you can do is walk into a room and do a pulse check, right? Because, and I'm talking about adults with complex childhood onset diseases, but this can apply to like a routine, healthy, college-aged kid who's 23 and never really actively participated in their medical care, and so mom's still coming to them to their appointment visit, and you're kind of like looking at them like, okay, wait a minute, what's happening here, right? So it's not necessarily that it's isolated to complex patients, it's just that it's more likely to happen. for people who have complex illnesses from childhood. And so really thinking about a spectrum and not using age cutoffs and thinking about where your patient is. And so when you do that, then your own expectations change, right? Then you know, who am I talking to? Who do I have to involve in this decision? And you yourself won't be disappointed if you talk to the patient and then like 5 minutes later, like something else entirely different happens and the dad walks in the room and the plan changes, right? You know who you have to involve in the medical decision making. And so it's important to acknowledge the patient at their level, because even if they may not be the only decision maker in their care, they're still a part of their care. And so knowing how to keep them within the dynamics of the decision making is critical. And then, as I said, clarifying the primary caregiver. So a lot of times there might be like 10 people in the room, but who's like the 1 or maybe 2 people who are gonna actually, when the buck stops and it's an emergency, who's making the decision, and identifying who that is important. And then the last thing I wanna really emphasize, because sometimes, and I myself do this, trusting the caregiver's intuition. So it's kind of like the worried parent for like a kid who's like, something's not right, but they can't tell you what's not right. And as a pediatrician, like our little spidey senses go up and we're like, okay, let me just reevaluate, do a closer physical exam, maybe watch something more closely. And we tend to listen to parents when they tell us that, right? As adults, if like your adult patient is like, I really don't feel good about this, but you have like your exam, your objective data, that CT scan that tells you their belly pain is nothing, right? You're more likely to say, objectively, you're fine. Keep an eye on it, follow up with your provider as an outpatient. Now, the reason I'm bringing this up is because in adults who've had illnesses since childhood, their body sometimes does not respond the way that we expect it to. And it may be the product of their chronic illness, it may be a product of something else entirely, it sometimes doesn't make any sense. But if a caregiver is telling you, hey, something's not right, or they're telling you something that doesn't quite fall into like the black and white of medical knowledge, take heed. So for example, and this is the best example I have. I haven't actually had a situation that's similar to this, but this was a couple years ago. I had a 19-year-old who had spina bifida who was admitted to the hospital. And the mom, and her UA was of course dirty, but it's always dirty. And she had a fever, and it was kind of like, all right, well, does she have a UTI? And I kind of was like, I don't think so, but like, that's what she's getting admitted for. She was kind of meeting sepsis criteria, which, as we all know, everybody can meet sepsis criteria with a fever and tachycardia, right? But the mom was like, you know, I don't think this is an infection. And I was like, oh, okay, why? And she was like, because she didn't break out in a rash. And I was like, what? And she was like, yeah, every single time she has a bacterial infection, she breaks out in a rash. And I was like, oh, does she have an allergy to an antibiotic? She was like, no, she just always breaks out in a rash. And lo and behold, I was like, well, let's watch off antibiotics then, and maybe we'll just check a viral panel, because did you say she had a runny nose? And she was like, yeah, she had a runny nose like yesterday, but I don't know if it was like minor. She had rhinovirus, and then we discharged her. But if the mom hadn't told me that, I probably would have erred on the side of caution and been like, all right, let's treat you as an infection. And so that has zero logical explanation. To this day, I don't know why she would break out in a rash, but that's what happened. And so trusting that these people who have taken care of their loved one for so many decades, if they tell you something that doesn't quite make sense, listen. It doesn't necessarily mean you have to act on it, but do take it seriously. And then in transitioning phases of care, so this one, I feel like we're shifting towards this for all patient care, but I always like to emphasize it, especially for people who have more complex conditions. Medical reconciliation is the patient's #1 lifesaver. Especially when you're dealing with diagnoses like congenital heart disease or like refractory epilepsy, getting dosages right and finding out, okay, what actually was adjusted over the past week that might be causing you these issues, and having conversations about it directly with providers assuming care. And so that means that if the patient's in your clinic and they have to come to the hospital, talking to somebody at the hospital. That means that if you're at the hospital and you're discharging them, talking to the provider that they're actually following up with as their primary care. It sounds obvious, but in our busy lives and days, it's much harder to do, but it does end up actually saving you time, and it actually saves, well, obviously the healthcare system, because it reduces the risk that they're going to be readmitted. And then the final thing I want to just share with the audience is a website, like a resource for your toolkit. How many of you guys have heard of the website Got Transition? I see no nodding heads. Okay, so this is a online tool for patients, families, healthcare providers, researchers, advocates, the whole shebang. It's a pretty dense website. However, it's great because it has clinical resources, it has toolkits for families, it has QI toolkits for clinics, and it also has like helpful videos. And the reason I say this is your like springboard into this world is because there's also different areas where it'll link you out to different subspecialty databases and websites. So that if you're like, I don't know what the clinical guidelines are for sickle cell disease, if you go to gottransition.org and search under clinical like resources, it'll actually tell you where you need to go there. And so it's a really nice resource, not just for providers, but for families as well, especially when they're kind of dealing with the changes in the dynamics. All right, so I'm just gonna take a momentary breather. I loved this picture. It's kind of like babies as old. I don't know why. Babies dressed as old people just makes me laugh. Also, newborns tend, when they got wrinkly skin and they look like a little gramps, that also makes me laugh. But the thing is that this picture really does say it all. Like, life is a spectrum of care, and there are moments where we can treat adults as little kids and little kids as adults, and there are reasons for doing so. All right. So the last part of what I want to talk about, and the question that I want to kind of pose to the audience more and really expand our box is, can I treat kids as adults? Don't worry, this is not a trick. I'm not just going to say no and wax poetic about how kids are not little adults. There are situations where we have to think outside the box and understand that there is a gray zone when it comes to this. Frequently, the reason that people will dogmatically say, no, you can't treat kids as little adults is because kids are different. That's just fact. So that is science. I'm not going to sit here and tell you that you can give the same dosages to like a 10-year-old as a 30-year-old. But from a physiology standpoint, kids have larger body surface areas. They have thinner skin. They have a higher metabolic rate. They have a more immature blood-brain barrier. And so the medications that you use for certain treatments in kids is different than in adults. The dosages are different, and their response to medications are different as well. You can get toxicity in a kid from topical creams, not as common in adults, right? And so there are definitely physiologic differences, and there's also obviously developmental and psychosocial differences. However, these physiologic differences we theoretically say are done at the age of 18, right? But everybody's body is different. So we also have young adults who are in their early 20s where I'm sure you guys have prescribed medications and you're like, wow, you're really sensitive to this medicine. Let me like reduce your dose in half, even though that's technically not like the FDA approved dosages for a therapeutic effect. So we artificially will say like, oh, at age 18, this is when we start treating you like this. But it could start at 16, it could start at 19, it could be at 17, where the body has actually finished maturing physiologically. And even for an adolescent, that might be when they've like reached a more adult approach to life and they've actually transitioned from a developmental standpoint. So while there are definitely reasons we don't treat kids as little adults, the way that I'm going to push the boundaries is by saying and pointing out situations where, hey, adult medical knowledge and practice does actually inform us about pediatric care. I think the one that's most obvious is mostly with adolescent medicine when it comes to sexual health, contraceptive counseling, mental health issues. A lot of the diagnoses that pediatricians can or family doctors can treat without the consent of parents, right? And a lot of that is you're assessing the maturity of the patient. You're talking to them about serious things, right? Like pregnancy risk, STI risk, HPV and cervical cancer risk. And so a lot of that information is actually informed from adult guidelines. Now, the other scenario where I often think we really have the application of adult guidelines and practice to pediatric care, and I don't know if the group also will kind of think in the same way, but the pediatric obesity epidemic. So obesity is obviously increasing in America, both in adults and kids, and in pediatric obesity, it is rising exponentially. And when we're dealing with the complications of that care, there's not a lot of data, right? It's not like you're sitting there going, okay, this 14-year-old who has high blood pressure and type 2 diabetes, this is what the guidelines tell me to do. There's a lot of gray zone, and providers are really struggling to figure out how aggressive do we need to be about the management because the data is just not there. And in case anybody needs to be convinced that pediatric obesity is a problem, the rate for or prevalence of obesity for youths ages 12 to 19 has quadrupled since 1980, and we spend about $14 billion annually just on pediatric obesity alone. So it is a big problem, and as we know, if that continues into adulthood, you get a lot of issues, right? So many of the issues and ailments that we deal with in adults is a complication of their lifestyle choices. And unfortunately, that does now transmit to kids as well. And so when you're looking at this list and you're like, okay, if I had a 14-year-old who had sleep apnea and they had obesity, am I doing a TNA, tonsillectomy, adenoidectomy, and seeing, hey, if their sleep apnea improves? Or do I just say, hey, this is related to your weight, let's do some weight loss and get you on a CPAP machine, right? Now, for the group, they're probably like, all right, why would I do a TNA on a patient who's obese with clearly like sleep apnea, right? But that is frequently the pediatric approach to sleep apnea. They try to say, okay, are there other causes of your sleep apnea aside from just your weight and your body habitus? And so that's just like one example, right, of how we have adult-based principles, and in the kids, we're like, okay, do I treat you like an adult in terms of the approach, or do I kind of approach it more like how I would approach like a 6-year-old who's not obese with sleep apnea, right? And so when we're thinking about these situations, in my mind, and I think it's because I'm a med peds provider, there are many moments where I'm like, okay, we can and perhaps should use adult-guided principles and medical knowledge for pediatric care. And so I'm going to use a clinical case of a pediatric admission that we had to hopefully illustrate this point. And then once we kind of get through this at the end, I'm going to open it up for reflections, questions, etc. And so also full disclosure, this case is not meant to be like to stump the audience or anything. It's pretty straightforward. So we have a 16-year-old obese male. He came in with a 3-day history of chest pain and progressive shortness of breath that was worsening over like about a 3-day course. A week prior, he had a right knee ACL repair from a football injury. He was the linebacker on his team. And he'd been largely immobile since kind of his leg was in a cast. He doesn't have a family history of blood clots. On exam, aside from having a BMI of 45 and a weight of 146 kilos. He was a little bit tachycardic and tachypnic, and his right lower extremity was pretty edematous actually. But per the ortho docs that he had seen 2 days prior, that was the routine healing that was going on. So this isn't meant to be a surprise. I'm sure everybody in the audience is like, he's got a PE. Or I assume everybody in the audience was probably going down that route. And so he was diagnosed with a left lower lobe PE, and then started on Lovenox twice a day and Coumadin. And then his anti-10A levels were followed for 3 days. Not all inpatient. He was discharged after 36 hours. And then it took him about 2 weeks to get therapeutic on his Lovenox, or on his Coumadin, and then his Lovenox was discontinued. Now, all of that probably sounded pretty routine to the audience. I assume so. Maybe. Hopefully. But what I want to reflect on is different aspects and phases of this patient's care and the clinical considerations of, as I said, can we treat kids as little adults? So number one, he's 16 years old. He has a BMI of 45. He had probably the emotional maturity of like an 18-year-old. Like he was pretty independent in his history giving and knowing his medical history and being able to tell me how he was taking his oxycodone for his pain, which is actually pretty good for a kid that age. And so he was developmentally there. However, I will say he was deathly terrified of needles. And he was like very, very much not wanting to do his own Lovenox injections at all. And vehemently told me so when I was admitting him. But the first clinical consideration in terms of his triage is admit or discharge. So his clinical exam, he was fairly hemodynamically compensated. One could argue that with the heart rate being high, all right, just keep him admitted and observe him for that. But he wasn't hypoxic. He was breathing relatively comfortably. He was just having a lot of discomfort, but he said it would go away with Tylenol. So a lot of times in the adults, we'd kind of be like, all right, let's do Lovenox, Coumadin, watch you for like 4 to 6 hours in the ER and maybe discharge you or decide on admission, right? In the pediatric realm, they all get admitted. Like I don't know any case where you would be like, oh, you have a PE as a 14-year-old, time to go home. They get admitted and their anti-10A levels are monitored because we want to make sure that they meet their therapeutic goals on their Lovenox levels. In adults, again, with your pharmacokinetics assuming that maturity, we don't follow anti-10A levels routinely. We just have that 1 mg per kg dosing, and we say, you're set. For him, if he did not have the elevated BMI, one could possibly argue that, hey, did he actually even need the anti-10A levels? But the person who informed that was a pediatric hematologist. If you had called an adult hematologist, they might have actually said something different because the data for adults says to only follow anti-10A levels for BMIs greater than 50. So right then and there, you have this question of, okay, how do I approach this patient? Because a lot of his problems, right, reflects as an adult, where you're like, immobility, recent surgery, PE, right? But he ended up getting admitted, honestly, appropriately. So there was a lot with his Lovenox that had to be discussed. In terms of the diagnosis, so in the ER, how quickly do people get CTPEs, right? It's like, if you're thinking of PE, you order it. In the kids' world, you don't want to expose children to radiation. You think twice before you order any test, including blood work, because it's like a big deal and you have to explain it to the family. And so this kid actually, the pediatrician, I touched base with the pediatrician, and she was like, I really was thinking about getting a CTPE the day before, but I kind of was like, could this be atelectasis? He was immobile, or like an early pneumonia. I really didn't want to expose him to radiation unnecessarily. But as an adult provider, or if maybe she was like family medicine, they may have just gone straight to the CT scan, right? And so that right there, again, is where we grapple with at what point do we approach this as an adult versus like a kid. And then the biggest clinical consideration that I really thought was a med-peds moment was the therapeutic options. This kid was really not wanting to do Lovenox. Like, he told me very explicitly, I'm not going to inject myself with Lovenox. And both his parents were working, and I was like, well, you have to do this twice a day. So how are we going to actually do this? Thankfully, both parents were able to, get trained on doing the injection, and they were comfortable figuring out a schedule at home that would allow them to do this. But the amount that there was a concern about his compliance with that, I really looked into whether we could give him something like Xarelto or Apixaban, which we use frequently, right, in adults, but unfortunately, none of them are FDA approved in kids yet. There's 2 phase 3 trials, which will probably come out in a year, that'll approve it, but as of now, it's not like I can say, these are the clinical guidelines and you are getting Eliquis because of it. But the conversation you could possibly have is, because I'm so concerned that the risk of your noncompliance with Lovenox is high, why don't we talk about using Xarelto or Eliquis as an alternative option, which hasn't been proven yet, but I think may be effective for you and may be a better option. And so that's a big gray zone, right? Because you're immediately going off clinical guidelines. But it's very possible that in a year or two, that would be the standard of care for these kind of patients. And so again, that right there is an adult medicine principle and knowledge that's guiding the change in pediatric care. And then finally, for the clinical consideration with discharge, so right, when we discharge adults, we just counsel the adult, and then we say, you need to know the instructions, you need to know the ER return precautions. And so for him, oddly enough, again, his parents were working, right? So we gave the kid discharge instructions, and then I was like, well, that's kind of weird. And so I was like, do you want me to call your mom or dad? And he was like, no, I got it. I'm like, okay. And I called his mom anyway, because I was like, that doesn't sound right. And the mom was like, oh, did you tell this all to him? And I was like, yeah. And she was like, oh, okay, yeah, he's got it. I'm like, oh, okay. And so really, that really goes back to the point that I've really been trying to harp on this entire talk, is that we frequently think about it as an age cutoff, but the reality is that you have to really look at where your patient is and where they are developmentally. And this kid, aside from his needle phobia, which honestly we see in adults as well, he was pretty independent in his medical care and decision making. And so appreciating that and adjusting how we approach is, again, kind of applying adult medicine to pediatric care. And so in reflection, before I open it up for questions, what are the lessons learned? So what is a MedPeds moment? Again, it is the simultaneous application of adult medicine and pediatric medicine and those principles of care to a single individual. And while it may not be on a constant everyday basis that you have these moments, hopefully each one of you in the audience has had some form of a MedPeds moment in your clinical career. And when we self-recognize these moments, it helps us identify how do these encounters challenge us? And so how do adults with childhood onset diseases challenge us? And hopefully I've given you guys some tools that are helpful. If the big thing you walk away with is the gottransition.org website, then that's great. And then finally, can I treat kids as little adults? Short answer, obviously no, but the long answer is that there is a gray zone in medicine, and that's where the art of medicine really comes in. And so I really push the audience to think about not the age of your patient, but where is this patient with their independence and acting accordingly to not only make your encounter with the patient more effective, but their experience a lot more effective as well. And I just want to put my contact up there. If you guys ever have a MedPeds kind of case or a MedPeds moment and you're like, I don't know what to do, or I need to find out who would be the best next step or person to contact, please feel free to email me or text me or page me, whichever way. I'm more than happy to help and hopefully get you guys connected. All right. Thank you. Yeah.
How often, if they have primary physicians, do you call the primary physician and get information about the patient?
Most of the time what triggers that phone call at the admission phase, like in the first 24 hours, is if the caregivers are not giving me clear information. So if they're like, this doctor did this and this other doctor did this, and I'm like, okay, what's actually happening in your preceding history? I'll call the primary provider. The challenge with that is that in the hospital, if they're getting admitted at 10 p.m., it's not their primary provider I'm getting in touch with, so frequently we have to kind of call the next business day to actually get in touch with them.
So, you know, the adult neurologist that is constantly getting kids with epilepsy to adults.
Yeah.
One thing I want to say is that MedPeds moment is not just the doctor, it's also the caregivers and the parents.
Oh, yeah.
They've had a doctor who they've trusted to take care of their kids since they were born. All of a sudden, there's this new person who may have different ideas or different ways of treating that are more geared towards adults. So there's a problem on both sides. And solving that, of course, is kind of clinical bedside manner and all those sorts of things. But I just want to point out that this is a two-way street.
Oh yeah, in Dallas I gave 2 talks to actually families with who were dealing with like kids with, you know, chronic illnesses, and like the simplicity of like telling them that like their child needed to start taking the lead on getting instructions was like mind-blowing. Like some of the things that you have to explicitly like tell these families is sometimes surprising, and that's why the Got Transition website is so great, because it's not just for providers, it's for families as well. But recognizing that the challenges from the family is important, because then it changes your bedside manner in terms of, you know, providing the reassurance and saying, okay, no, we hear you, we take care of you, we've got the records, we've talked to the doctor. You know, those are the things that they're looking for, those cues of, okay, can I actually trust this provider? And it takes time. It's not like they're gonna meet up with you and have an immediate like bond. It's just challenging, and it's not a challenge. It's not anything that the provider is doing wrong. It's just that they're readjusting to an entirely new system.
So my question for you is, does this patient have sleep apnea syndrome? Second part of it is, if the patient's obese and pediatric, when do you start thinking about Pickwick syndrome?
So he actually, I didn't put it on this, he actually was diagnosed with sleep apnea at the age of 13, and then he actually got a TNA. And then His second sleep study was borderline, and so they kind of were like, oh, you can use CPAP or not. He didn't meet a lot of the daytime symptoms, and so they kind of were like, well, we won't go down the CPAP treatment. As far as when to like think about Pickwickian and like when you're kind of going down that route, I would have to refer you to a pulmonologist. In all honesty, that's pretty subtle.
40% chance is CPAP doesn't work because it's the wrong treatment that he
Yep.
has to bypass. And if he has Pickwick syndrome, then he needs a directional BiPAP which breathes for him. And I don't know if he has it. Where was he worked up?
His workup, I think, was Randall's, if I remember correctly, but I'd have to look back in the chart and check.
So I just realized that I don't even know, is there a hospital policy that decides where teenagers get admitted? Like, is it 18? Is it?
So our cutoff for the well, actually, we just had an email where it was like, is our cutoff 18? But normally at the age of 18 is when we say, all right, you got to go to the adult world at St. Vincent's. But that strictness of that policy is actually variable by Children's Hospital. So for example, my brother, who's a pediatric cardiologist, had two 40-year-olds in the cardiac ICU last month. And I was like, that's uncomfortable. So yeah, so it happens, and it really does depend on the situation.
That's the hardest thing, going from your pediatric cardiologist to an adult cardiologist.
Oh yeah, and again, and the thing is like the care is entirely different because in the peds world, if you have an adult congenital heart disease, your primary phone call or as soon as something goes wrong is actually your cardiologist. It's not the general pediatrician. But in adult world, the primary care doctor, your family doctor, internist, what have you, is the gateway to these specialists. And so if you're like calling up the adult cardiologist frequently to be like, hey, I'm feeling this, they're kind of going to be like, who is this high demand patient keeps calling me? But that's again, managing the expectations and recognizing, hey, this is a med-peds moment. This is what the family was used to for almost 20 years of their life. So it's a changing process on both sides.
The rise in adolescent suicide and suicide attempts is a physical disease with the opportunity for the physician to see the individual at the time of physical disease. Is that possibly a tripping factor, and how do you think about that question?
So clarify the question. So you're saying like when you see them for their physical ailment,
Right.
and yours.
Is that adolescent depression and the hard to diagnose who's a suicide risk?
Yeah.
Is that sometimes part of the etiology of the suicide in some folks? And if so, what do you know about that?
Oh, in terms of because of their development and ability to express their feelings, is that the driving factor of their behavior? Oh, for sure. Yeah, for sure. It's something that we frequently see actually admitted on the peds floor a lot, right? If it is like a intentional ingestion or suicide attempt, like frequently they're not communicating how they're feeling. And then if they're coming in also with like nonspecific belly pain, frequently that's why we routinely do what we call a HEADS exam, which is a extensive social history where we assess their safety and other risk factors. And the trigger for doing that more detailed assessment is actually a very low trigger. So all pediatricians and family doctors out in the community will do this screening for like as a routine for all adolescents starting at, I think the recommendation is still starting at age 10. And in the hospital, I think most of the providers in our group, and we frequently will do that exam where we will screen them on admission because a lot of times their nonspecific physical symptoms and ailments are a representation of something else that's going on. And so I don't think that that's necessarily isolated to adolescents. I think the challenge with adolescents is that they're not going to be forthcoming and they're not going to be able to recognize that link. And so that's why when we do these, like the HEADS exam, it's meant to help us in these situations where they have some physical ailment like headache, but we're like, is this migraine or is this actually like your stressful year in school you've had with bullying over the past 6 months? Any other questions?
I
they're like younger, like in their 20s when they're seeing you?
Middle
Middle
age,
age, okay. The reason I'm asking kind of the age is because in the pediatric approach to developmental delay and like intellectual disability, their IEP, so individualized learning plan at their school, frequently has the most detailed in terms of their reports. And parents are usually pretty good about kind of keeping track of that. And then their home therapy services, so speech therapy and then physical therapy and occupational therapy. So frequently the kind of way that's best to gauge during that transition phase is kind of like, well, what are these therapy services working with you on? And what were you able to do functionally? For the younger ages, they frequently will be in like some sort of like vocational program, and then you'll know that if they're more severe, if like parents are talking about like adult daycare programs that they go to on a regular basis. So kind of taking the cues on their community resources can help inform like what your expectation of their cognition can be. There really aren't validated like adult tools for this yet in terms of like, oh, you've had this since childhood, how do I keep a track of this? And so we use the adult tools for their assessment, but it is deficient in that it's like a different pathophysiology and approach. Yeah, so I always kind of say the support resources are kind of where you're going to get the most information and kind of tracking that over time. And the biggest thing that's a challenge, and this was in the transition clinic in Houston also, is that when you become an adult, you lose a lot of those therapies and services. And so having your social worker or case manager get them linked up to like a transitional program is important. And then once they're connected with those community resources, following up on how they're doing with that can be very helpful. But unfortunately, no validated tools. Any other questions?
Thanks so much for
Thank you.